Thank you, Dr. Oz. During the transition last January, one of the people I was bringing on as a special government advisor was a long-term friend of mine called Jake Levine. And I asked Jake, can you give me an agenda, the most important things that we can do very quickly as soon as we get in there? And Jake called a professor at Harvard named David Cutler, a famous economist who spent an entire career studying the healthcare system and advising reforms. And he posed that question to Dr. Cutler. He said, what is the single most important thing that we could do to improve the patient experience in this country? We could do very, very quickly without regulations and without legislation. And Dr. Cutler immediately said to him, you can convene the insurance companies and get them to voluntarily agree to end the scourge of pre-authorization. And very early on in the administration, we brought in Chris Klump. And Chris Klump, I'm going to ask Jake and Chris Klump to come up and join me. Chris Klump was a very, very uber successful healthcare entrepreneur from Silicon Valley who specialized in healthcare technology. And in building his company, he had met virtually all of the big insurance CEOs and hospital CEOs in this country. And he spent the last several months calling them each up one by one and getting them to agree to this program. And it was an extraordinary effort. I'm so happy for his leadership, for Jake's leadership on this issue. The two of them have been working hand in hand to make this extraordinary day happen. And it's so important for our country because this has been one of the worst things. As Dr. Oz pointed out, 85% of Americans say that they have had delays in healthcare because of prior authorization. And the doctors hate it. Doctors report that it costs them 12 to 15 hours a week filling out forms. Some nurses are spending over half their time dealing with the administrative burden of this. And healthcare is often delayed to Americans. The cost of administration is enormous to our healthcare system, and we're going to be able to eliminate a lot of those costs by what we're doing today. I just want to read you an experience that a very close friend of mine, who's a physician, had with this, one of his many experiences, bad experiences with pre-authorization, and this is all too common in our country. A patient from New Jersey suffering from severe heart failure was transferred to New York Presbyterian Hospital for a life-saving transplant by my friend, the doctor. To survive until a donor heart became available, the patient urgently needed a mechanical heart pump, a device essential to sustain their life during the wait. The insurance company had approved the heart transplant, but then denied authorization for the mechanical heart pump, deeming it unnecessary. The decision created a perplexing contradiction. The patient was cleared for a transplant, but not for the critical device needed to keep him alive until the transplant could happen. With the patient in the operating room and his life at stake, the medical team was faced with a profound ethical challenge. Should they adhere to the insurance company's denial, which would likely lead to the patient's death, or take action to save the patient's life, knowing it could result in legal or professional consequences? The medical team chose to prioritize the patient's survival. In planning the mechanical heart pump, this decision allowed the patient to live long enough to receive a successful heart plan. My friend, the doctor, was then sued by the insurance company. And ultimately, that lawsuit was dropped. But there are many situations in this country where that ethical decision, for one reason or another, would not have been made, and people lose their lives because of prior authorization. In the past, the insurance industry has made commitments to prior authorization, but they have not kept them. And in this case, we think it's very, very different because, one, a number of patients covered by this is unprecedented. As Dr. Oz said, 257 million patients are covered by the group that we met with this morning. And while we were in that meeting, another company joined the group. And we expect we're going to have rolling enrollment, so we expect many other companies to also join. The other difference is we have standards this time. We have deliverables. We have specificity on those deliverables. We have metrics, and we have deadlines, and we have oversight. So we're all going to be, I'm very grateful to the insurance company for stepping up and the hospital systems for stepping up. We're all very, very grateful to President Trump for his leadership in giving us the impetus to make this happen. This has been something that we have been struggling with in this country for decades. 2 decades of presidents have promised to do this, and none of them have succeeded. Congressman Murphy has been working on this issue for 35 years. And it's a priority for him, and it's been a priority for many people in Congress. And can I ask Congressman Murphy and Senator Marshall to come up as well? So, you know, today, because of President Trump's leadership, we are agreeing to this momentous and monumental achievement. And we hope to see the dividends of this success story immediately materialize as a better experience for the for millions, hundreds of millions, literally, of American patients. I want to thank all of you for being here, and we're happy to take questions.
We do have another live event that we want to go to. We do have Dr. Oz here, the head of the Centers for Medicare and Medicaid. He is speaking ahead of Secretary Kennedy, speaking on health insurance. Let's listen in on Live Now from Fox.
And this transition that's not happening, this teaching that's sort of spreading, is beginning to catch fire in part because this administration has pushed so hard on these issues. We're hearing very innovative ideas. For example, could we allow some physicians to be gold card physicians because they're so good at making the right care for the right patient that maybe they don't have to go through a pre-authorization. There's some systems that don't even do pre-authorizations because they have already evolved into having ways of giving feedback to doctors so they learn when they're ordering tests and medications that aren't the right for a solution to a particular problem, so they don't repeat those errors. At its best, that's what pre-authorization sought to do, but that's not what it's doing anymore. So for that reason, the pledge. And some of the highlights are in this chart to my right, so you can at least follow along. But I'll mention that the top 3 issues that we're focused on. The first is timely access for patients. This is a critical issue because imagine you're in a doctor's office and you've got a bad diagnosis and there's a procedure or a test or a treatment that you think is right for you, and you find out that you can't start that treatment for sometimes weeks, even longer. It's more frustrating than anything else in the process because at least that's something you do control. You don't control much else when you're in a physician's office with that kind of a crisis. And yet it's withheld. And these approvals with this new pledge will be streamlined. It will happen very quickly. Necessary care will be delivered when it's needed in the right way. So you get both quality and you'll get timing, which goes along with that quality. And you won't get that treatment after all the paperwork clears. You'll just get it because there won't be paperwork. We'll be streamlining it. Patients should not be waiting because bureaucratic hurdles are blocking their critical treatment. Second big issue is to make sure that we are saving the system with efficiency. I bring that up because one of the biggest challenges we have within CMS, which is, again, Medicare, Medicaid, the exchanges, is that it's an inefficient process by which we do things, by which we give feedback, by which we send bills and collect. The red tape creates massive problems. We want less red tape, and if we do that, we can cut tens of billions of dollars of administrative waste. It's a lot of money that we throw at solutions that we don't work for us because we haven't built a digital infrastructure that's being addressed. With less red tape, that means more resources for patients, which is part of the reason these major companies got together, working together with the Health and Human Services Agency to try to take a shot at the pre-auth process. We'll standardize, we'll harmonize, we'll get folks talking together, and the pre-authorization process, if it's done correctly, for ongoing procedures, for medications and the like, will create a seamless relationship between patients and providers, which is the whole goal in the first place, to allow them to free them to get across the finish line with their treatment plans, but to do it together with the insurance entities, the folks that are responsible for these different plans. And thirdly, transparency. And transparency comes with accountability. If you now know what's going on, you now have the responsibility of dealing with it. We have common data standards. They're going to be adopted, and public dashboards are going to reveal to you and to patients what's going on. So we'll be able to audit if this is really happening, because although we're hopeful, this is hard to do. And folks sometimes change their mind. We don't want that to happen. So we're going to trust but verify by having this transparency and accountability. All the stakeholders, the payers, the providers, the patients are going to see real-world performance. And by having that, they'll be able to assess whether this is clearly and consistently accomplished. Now, the pledge is not a mandate. This is not a bill or rule. This is not legislated. This is an opportunity for industry to show itself. Participation is voluntary. But by the fact that 3/4 of the patients in the country are already covered by participants in this pledge, it's a good start. And the response has been overwhelming, gratifyingly so. The effort took place with the government as a sponsor, as a steward, as a cheerleader. It was led by wonderful people who realized that we had an opportunity to do good, and that government, you don't have to always do it yourself. You can use the power to convene to pull together powerful interests. We have discussed extensively with individual physicians this idea. We've talked about it with health systems, with associations, with congressional partners. You'll hear from some of them in a moment. CMS is going to publish a full list of participating plans later this summer with some details of how it's going to roll out. And the initial commitments, like, for example, code reductions, the number of procedures that would have to be subjugated to pre-authorization or similar limitations, the continuity of care protections to make sure that you don't lose coverage when you switch between plans. It's going to go live by January 26th. It's a fast timeline, but in 7 months, we'll be able to give to the American people something they've been asking for, something that's been in the news recently because of the difficulty of obtaining it, which is the freedom from prior authorization when used incorrectly. So what's the blueprint for broader reform? Because we see this as the first of a much larger opportunity. This is getting everyone together on a pain point, a thorn in everyone's side, a pebble in our shoes, but the real opportunity is use this as the first and very important step in building a larger blueprint, because it's not just about prior authorization. It's a template for administrative simplification, to take the paperwork out of the process and put patients over paperwork. There's going to be a single FHIR-based electronic workflow. FHIR is a fast healthcare interoperability resource, so it's a standardized way for information exchange across systems. We'll have real-time decision-making for most electronic requests by 2027. We're going to have to work with providers, with doctors, many of whom, maybe half potentially, aren't using these kinds of technologies routinely in their office practice when they interact with insurers. We want that to change. We don't have a slowing down of the process. There shouldn't be paper, there shouldn't be faxes, there shouldn't be letters being sent. They should all be done digitally and automatically, and 90-day continuity should exist for authorizations when patients switch insurers, so you never fall through the cracks. Again, another pain point that many patient groups are bringing to us. The future is a system where carriers compete on value and outcomes. They compete on value and outcomes. They do not compete on issues like confusing portals and who can obfuscate the most and delay the process the most. That's not how they want to win, and that's not how they're going to win. We want to recognize the insurers who've done this, and they have stepped up. They're sharing data in ways that we are, very honored by. They're willing to be meek in the process in ways that we had not even initially anticipated. They're accepting performance targets. They're offering commitments that go just beyond the profits that are involved in this process, although we're hopeful that we'll actually save some money through this process, because we won't be wasting the amount of money that is often spent unnecessarily when documents are sent back and forth, taking up precious time without changing the overarching results. This shows what's possible when policymakers get together with payers and they can join forces to make the care faster, simpler, and more affordable for the American people. So what comes next? Well, today's the beginning, and it really is just that. As this process rolls out, we're going to be seeing exactly how the engineering occurs. CMS is engaging with providers to find out how they can refine documentation procedures, because that's often where the entire process gets stuck. The records never get out of the doctor's office in a timely fashion. We have patient advocates identifying low-value codes. There's some things we should not be pre-authorizing anymore, and we should stop that, and the insurance industry agrees with that, by the way. The health IT innovators who are out there who want to help, there's an opportunity for them to extend real-time prior authorization. So literally, as the decision is being made that you as a patient need a test or a medication, the decision is at the same time made by the insurance company that it's okay. And this is going to allow us to next proceed into looking at ideas with pharmacy and behavioral health. So those opportunities and pre-authorization processes are accelerated. In closing, I'm going to applaud the insurance companies for taking a very thoughtful, brave first step. That stated, I know that we're going to have to keep watching what everyone's doing carefully. I want to be clear about that. In reality, if the insurance industry cannot address the needs of pre-authorization by themselves, there are government opportunities to get involved. They might not be as nimble, but they will be used if we're forced to use them. We've, I think, convinced all the folks to come to the table, and I'm optimistic with that we're going to be successful. And there's a lot to be said about this, but I want to bring some folks in who have been very actively engaged in this process. I'm going to start with a gentleman who's known to many of you because he's been on television in front of tens of millions of people playing an active role as a doctor, although he's not a doctor in real life. But he does have a health problem that has, and is chronic, so it's going to force him to deal with the pre-authorization system. And this is an exact kind of situation where you don't want pre-auth hindering and limiting your ability to get the care you need. Some of you know him as Dr. McSteamy from Grey's Anatomy, but Secretary Kennedy and I call him friend Eric Dane. Eric, come on up.